the outset, I thank Dr. Jodhdev and his team of doctors and staff for inviting me and allow me to chair the session. The topic is Type 1 Diabetes Mellitus, Roaring Lion. Can we stratify the risk and customize protocol? It is good that he has included a topic like this, Type 1, because always we hear about Type 2 and lot of drugs like SGLT2 inhibitors and gliptins, etc. And we know that the Type 1 is also increasing day by day, and about 5 to 10% case of diabetes are now Type 1 cases, and globally it is on the rise. And even in India, it is about 10.6 per year per million cases are reported. So for this, so we need to know that what new strategy, what are the updates and all that. And for this I invite Dr. Ranjit Unnikrishnan, who is currently the Vice Chairman and Consultant Diabetologist at Dr. Mohan's Diabetes Specialty Center, Chennai. And he was a faculty in ADA and IDF, and he has several publications in the leading international and national journals. For delivering the lecture, I invite Dr. Ranjit.
Thank you, sir, for the kind words of introduction. At the outset, let me thank Dr. Jodhdev and the entire team for once again inviting me to this beautiful city and to address this August gathering. As we are running short of time, I'll go directly into the topic. I've been asked to talk on what are the ways and means of stratifying the risk of type 1 diabetes and customizing the protocols for the same. So when we talk about stratifying the risk, what we need to understand is not just the risk of developing the disease that we need to look at, but also the risk of developing acute complications of the disease as well as chronic complications of the disease. And based on that, we can probably come to some conclusion as to how the treatment protocols can be modified. So we all know that type 1 diabetes accounts for only around less than 10% of the total diabetic population. And there are a lot of geographical variation observed with countries at higher latitudes, particularly in the Scandinavian peninsula, being more affected than countries elsewhere in the world. Mostly occurs in juvenile population, but up to 10% can occur in elderly individuals. There are reports of people even up to the 7th to 8th decade of life developing type 1 diabetes. The incidence, as I will show in the next couple of slides, seems to be gradually increasing, but by no means is there an epidemic of type 1 diabetes as we have of type 2 diabetes, but the incidence seems to be increasing slowly nevertheless. It's not strictly a familial disease, but multiple cases can occur in the same family. We have a number of families in whom we have 2 or even 3 individuals affected with type 1 diabetes, probably because of the shared HLA susceptibilities genotypes. So as you can see, it's most common in some of the northern regions of the world, especially in the Scandinavian peninsula, and in countries where the people from these countries have migrated, like Australia, Canada, and the United States. You can see that the highest number of people with type 1 diabetes is found in Europe, followed by the North America, and Southeast Asia, of which India is a part, is also fast catching up. These are some of the few studies which show trends in the incidence of type 1 diabetes, mostly from Europe. You can see that there is a slow but steady increasing trend in the incidence of type 1 diabetes, not to the same extent as seen with type 2 diabetes. There is very little data on the situation in India, and the IDF Atlas, at least the last edition of the IDF Atlas, quoted an incidence rate of 4.2 per 1 lakh. Just compare that with the incidence rate of type 2 diabetes, which Dr. Mohan talked about just a few minutes ago. But the thing is that even this incidence rate of 4.2 is quite high, because in China they claim an even lower incidence rate. I think this is one of the conditions where China does not want to be ahead of India. Unlike type 2 diabetes, they want to show that they are much better off when it comes to type 1 diabetes. But the fact of the matter is that these studies in India are restricted to a few scattered studies, couple from Chennai, one from Karnataka and another from Haryana, Karnal in Haryana, Dr. Sanjay Kalra's group. This translates to around 1 lakh children with type 1 diabetes. But the thing to remember is that every 5th child with type 1 diabetes in the world is an Indian. Only 1 in 7 individuals with type 2 diabetes is an Indian. So we Indians are overrepresented in type 1 diabetes as we are in type 2 diabetes. So now let's see whether we can predict the risk of development of type 1 diabetes by some of the means we have at our disposal. Now we all know that type 1 diabetes has a clear-cut natural history, although the stages may not be very evident to us because of the fast natural progression. It starts with an individual with a genetic predisposition due to certain HLA antigens. Certain patterns have been described again which are different in Western populations as compared to India. And in an individual with this genetic predisposition, if such an individual is exposed to an environmental trigger, which may be a virus or some dietary factor or something else, there develops an autoimmune mediated attack on the beta cell, which is mainly mediated by the T cells. It's a cellular immunity. And as a part of the immune cascade, certain autoantibodies to various components of the beta cell are released. And these serve as useful markers of autoimmunity. These antibodies include ICA, IAA, anti-GAT65, IA2 antibody, zinc transporter antibody, and so on and so forth. And this is followed by a stage of pre-diabetes, which may be so short as to be clinically indistinguishable, and by the time most patients come to us, they have already lost nearly 100% of the beta cell function, and they are in the stage of frank diabetes. Now, what we mean by stratifying the risk of type 1 diabetes is that if we have somebody at risk of type 1 diabetes, can you predict as to what is the risk of actually developing the disease so that we can do something about it? And this is a study which was published around 10 years ago in Diabetes Care, and in which they looked at the autoantibody patterns and profile in relatives of patients who had type 1 diabetes and tried to stratify the risk of these individuals for developing the disease. They took 180 non-diabetic relatives of children with type 1 diabetes, and these people had to be positive for at least one of the autoantibodies which I mentioned earlier. And they were followed up for a period of 5.9 years, and around a third of them developed type 1 diabetes. And in these individuals, they tried to look at the antibody characteristics, including the titer, the epitope specificity, and IgG subclass, whether IgG1, G2, or G3, in order to estimate the predictive value for type 1 diabetes. And these were the factors which were found to be predictive for high risk of type 1 diabetes. High titer IA2 and IAA, IgG2, G3, or G4 subclass of the IA2A, and antibodies to IA2 beta. These were the autoantibody factors which were associated with the risk of diabetes. And based on the autoantibody profile, these individuals could be classified into 5 groups, with the 5-year risk of diabetes ranging from 5% in the first group to 89% in the last group. But we know that there are significant caveats to this study. A significant proportion of patients with type 1 diabetes are negative for all known autoantibodies. And this is data from the West, in which it is shown that even if you look at all the autoantibodies which are known for type 1 diabetes, only around 70 to 80% of individuals turn out positive. And this figure is even lower in India. Only up to 50% of our patients are positive for any autoantibody at the time of diagnosis of type 1 diabetes. In India, testing for autoantibodies is expensive. And finally comes a $1 million question: even if you do find someone at high risk of type 1 diabetes, what are you going to do about it? Are you going to just leave it hanging like a Damocles sword over the head of the patient that you are going to get, there's an 89% risk of you developing type 1 diabetes, but we're sorry, we can't do anything about it. So until such time as we have some preventive measures available for type 1 diabetes, the ADA recommends that screening for the risk of developing the disease be confined to research settings. That is the exact terminology which is used in the ADA standards of care, and that is what I think we should also be following as of now. Now we look at something which is more clinically relevant, and that is in individuals who already have type 1 diabetes, how can you stratify the risk of acute complications? And this is another study from Colorado, from the famous Barbara Davis Center, which looked at the predictors of acute complications, namely hypoglycemia and diabetic ketoacidosis in children with type 1 diabetes. They took 1,243 children, ranging from infants to those of 19 years of age, from Denver. They followed them up for around 4 years, from 96 to 2000, and they looked at the incidence of ketoacidosis as well as severe hypoglycemia, and they divided them into boys and girls. You can see that the incidence of ketoacidosis seems to remain constant, whatever be the age, in the case of boys. But there is a clear-cut increase in the incidence of ketoacidosis in girls as they grow older. That means as they enter puberty. Now, this may be due to different reasons. It may be due to the hormonal changes of puberty, or it may be due to some of the social-cultural or psychosocial factors. Girls in the US, they don't want to put on weight, they tend to omit the insulin, they tend to hide their diabetes from their peers at school, so they have to miss the insulin, so on and so forth. But whatever be the reason, it so appears that the incidence of ketoacidosis is much higher in adolescent girls than in boys. When you come to hypoglycemia, exactly the opposite picture. As girls grow older, the incidence of severe hypoglycemia, defined as hypoglycemia requiring third-party assistance, comes down, significantly reduces. Whereas there is not much of difference in the incidence of hypoglycemia with age in boys, and at any age it remains higher in boys than in girls. The predictors of ketoacidosis, psychiatric disorders like depression and other such disorders, they were significant in both boys and girls, but probably played a more important role in girls compared to boys. Underinsured, people who don't have medical insurance, again not very relevant to India. That's again another risk factor for ketoacidosis. Increased dose of insulin, again that probably selects out a population of patients with more severe diabetes. Otherwise, there is no reason why increased insulin dose would lead on to ketoacidosis. But that's probably because of bias. Again, as HbA1c increases, persons with higher HbA1c, again similar for boys and girls, they were more prone to develop ketoacidosis. If you look at the predictors of hypoglycemia, again psychiatric disorder, lack of medical insurance, more duration of diabetes. This probably reflects a higher prevalence of hypoglycemia unawareness, leading these individuals to develop severe hypoglycemia before they could develop the warning autonomic symptoms, and decrease in HbA1c, too tight control or inappropriately high doses of insulin. These were the predictors of severe hypoglycemia. So ketoacidosis seems to be a challenge in adolescent girls. Hypoglycemia affects the youngest patients disproportionately. I will come to that towards the end. Boys are disproportionately more prone to severe hypoglycemia. Underinsured children, those with psychiatric disorders, and those at the extremes of the A1C distribution need to be specifically targeted to prevent these two acute complications. In fact, we often say that in a patient with type 1 diabetes who is not on the CSIA pump, a normal HbA1c or even an HbA1c below 6.5% should prompt you to search for undetected hypoglycemia. Don't be very happy saying that the patient is under good control, because it's virtually impossible to get an HbA1c of 6.5 in type 1 diabetes who is not on the pump unless they have significant hypoglycemia. Again, the applicability of these findings to Indian patients is open to question, but it's a point for thought. Now I'll talk about the risk of chronic complications. Is there any way by which we can predict these? And this is a cohort from Denmark, a Danish cohort of pediatric diabetes, which was first established in 1987, which included 75% of all the patients in Denmark with type 1 diabetes. One of the advantages of being in a small country. They repeated evaluation in 1995 and 2011, and they did something very interesting. They looked at the retinal vessel caliber, that means the diameter of the retinal vessel, and something very complicated known as the retinal vascular fractal dimensions. They just superimposed a frame on the retinal photographs, and they had the computer program which looked at the complexity of the retinal branching, vascular branching. And they tried to look at the relationship between these characteristics and the microvascular complications. And they found a consistent relationship between the narrower retinal arterioidal calibers, wider retinal venular calibers, and lower fractal dimensions on the one hand, and the 16-year incidence of not only proliferative retinopathy, but also nephropathy and neuropathy. Now, this is very interesting, because all you need is a retinal photograph and this particular software for calculating the fractal dimensions. If you have that, at least in this population, you can predict the long-term incidence of all the microvascular complications of type 1 diabetes. Here again, we have the Jocelyn study of the medalists. Medalists are people who had diabetes for 50 years, and there are a good number of them right now in the US. And this study looked at 351 US residents who have survived with type 1 diabetes for more than 50 years, and they looked at the complications, and they also looked at the advanced glycosylation end product production in these individuals. And they found that a high proportion of medalists remained free from all these complications. This is what is known as survivor bias, because those who had these complications, severe complications, probably passed away much earlier. They didn't survive for 50 years. And glycemic control, funnily, was unrelated to complication. And they remember it's not just one HbA1c, but the trend in HbA1c was unrelated to complications. And individuals with this particular advanced glycosylation end product, that is carboxyethyl lysine and pentosidine, were found to be 7 times more prone to develop any of these complications. So this is probably one of the risk factors for developing the complications. And another interesting thing is that of those individuals who did not have proliferative retinopathy, 96% without retinopathy progression over the first 17 years did not experience worsening thereafter. That means if you have retinopathy, stable retinopathy, 17 years, you are not going to get any progression thereafter, which has significant implications in planning screening programs if such a finding can be replicated in our population. So finally, we'll talk about the individualization of treatment protocols. Now, until around 3 years ago, this was the ADA recommendation for pediatric diabetes. You can see that very beautifully they are given different targets for different age group, toddlers and preschoolers, school age individual, adolescents and young adults. And you can see the HbA1c targets come down as your age increases. And the main reason for giving these individualized targets is because of vulnerability to hypoglycemia. Children are unable to report the symptoms of hypoglycemia, and we really do not know what effect repeated hypoglycemia might have on brain development and cognitive development in these individuals. But now, lo and behold, for the last 2 years, the ADA has removed all the individualization. They still say it should be individualized, but they have kept one size fits all HbA1c for all children, 7.5. And the only reason I can think of why they have done this, hypoglycemia is still an issue. But probably it has become less important because majority of children with type 1 diabetes in the United States are now on the insulin pump. So probably that's why they have removed the worry of hypoglycemia from majority of these guidelines. But still it is not relevant for India because most of our patients still cannot afford the pump. So I leave you with a few points to ponder. As I see we are running short of time. We talk about the 7-point SMBG. We all know it may not be very relevant to us because many of our patients cannot even afford 1-point SMBG, leave alone 7-point. So we need to find out individualized protocols for the same. Analogs, of course, very useful. Most of the studies looking at benefits of tight control recently have looked at the analogs, but again, they are prohibitively expensive. Continuous glucose monitoring, ambulatory glucose profile, very useful. Again, the cost is an issue. And of course, the use of CSIA pump, as I said, has resulted in changes in the guidelines in the Western countries, but probably not in India as the time comes. Thank you for the patient attention.
Thank you, Dr. Ranjit. And if there are any questions, maybe 1 or 2 questions can be.
Yes. SGLT in type 1 diabetes, is it? In fact, it's not a licensed indication, and right now I don't think we can advise the use of SGLT2 inhibitors in type 1 diabetes because majority of the cases of ketosis and acidosis which have been reported in use of SGLT2 have occurred in type 1 diabetes, off-label use. So probably right now is not the time to talk about using these agents in this particular population.
Sir, any other drugs like alipacid or anything like antipsoriatic?
Which one, sir?
Antipsoriatic, any biologics, anything?
See, as far as the treatment is concerned, people have now looked at replacing the beta cells, either by whole pancreas transplantation or by islet cell transplantation or by stem cells. Now, each has got its own pros and cons. Pancreas, of course, is a major organ transplantation with all the attendant ills of immunosuppression, major surgery and so on and so forth. Islet cells, you don't need that much of immunosuppression. Surgery is simpler, but to get the islets, sufficient number of islets for one recipient, you need at least 2 or 3 donors, which may not be easily available in a country like ours where organ harvest is not there. And even if you do transplant sufficient number of islets, 10 years after the procedure, more than 85% of patients are back on insulin. So you do all this and at the end of the day, you're back on insulin. Probably your control is slightly better, but you still need to take the injections. Stem cells, of course, the problem is that again you need to give immunosuppression because the same autoimmune process that attacked your original beta cells are also going to attack the beta cells which are formed from your stem cells because they are your own stem cells. So again, that's an issue.
If there are no more questions, we can close the session. Thank you, Dr. Ranjit.
Thank you.
Thank you, Dr. Ranjit and Dr. Mohan. Now I request Dr. Vinita Nair, Medical Officer, BSAC, to hand over the memento to Dr. Ranjit and Dr. Mohan.